Dear viewers, welcome to our channel. Today we'll talk about oxygen therapy. Before going to that, I want to say you have to take in mind that oxygen is a drug, so it should be prescribed. It should be given by trained person because oxygen therapy, if it is inadequate or if it is excess, it can harm your body. And also I highly recommend to go through the guideline or the article given under most of the slides here to know more about oxygen therapy. So what we will learn after this session? After this session, we will know general consideration of oxygen therapy. We will see some oxygen delivery devices and know about them. We will learn about the oxygen therapy in different situations. We will discuss briefly oxygen therapy in COVID-19 patient, and there will be an overview of mechanical ventilation. This session is not include the oxygen therapy in ICU patient. In our next videos, we will discuss more detail about mechanical ventilation. In this session, we will discuss only about the patient which we manage in our general wards. So some fact about oxygen. By volume it is 20.9% in the air, and if according to weight it is 23% of air. It is non-inflammable gas. It accelerates combustion, and you should bear in mind that it is a drug, and it is the common drug which is used in emergency medicine. Here you can see the molecule of oxygen. So how we can define oxygen therapy? Oxygen therapy is the administration of oxygen at concentrations greater than that in ambient air with the intent of treating or preventing the symptoms and manifestation of hypoxia. So important to note that oxygen therapy is given due to hypoxia, not to ride out of breathlessness, because breathlessness may cause due to different kind of diseases. But where is hypoxia, we should use oxygen there. If there is no hypoxia, it will not reduce your breathlessness. There are some common misconceptions about oxygen therapy. I have shown here. Common misconceptions are oxygen relieves dyspnea. No, I just say that oxygen only reduce hypoxia, not dyspnea. Cannot give too much oxygen or less oxygen. In some situation, we have to give a large amount of oxygen, such as in COVID-19, a large amount of oxygen needed. Lack of appreciation, hyperoxemia. In some situation, there may be no need of oxygen, but you are giving oxygen that may make harm the patient, such as in myocardial infarction. If you give oxygen, if the patient have no hypoxia, then it can harm the patient by accelerating the infarction size, because hyperoxemia causes vasoconstriction. And same example is also applicable as in stroke. So, important things should be noted. Oxygen is treatment for hypoxemia, not for breathlessness, not for the cause of hypoxemia. So, hypoxemia should be evaluated. Types of oxygen delivery system. Types of oxygen delivery systems are compressed gas cylinders, liquid oxygen in cryogenic containers, and oxygen concentrators for medical use. Here you can see that multiple sizes of oxygen cylinders which are commonly used in wards. Here in the left side photo, it is oxygen delivery where cryogenic oxygen is stored and by pipeline supplied to the ward. And this is a oxygen concentrator from which oxygen can be used, by which oxygen is used from the environment. Oxygen is separated by this machine and delivered to the patient. Delivery of the oxygen to the patient. We can deliver to the patient with low oxygen delivery devices and high oxygen delivery devices according to the needed. First of all, nasal cannula. Which can give up to 6 liters per minute of oxygen and provide up to 50% of fraction of inspired oxygen. By simple mask, we can provide up to 10 liters per minute. By Venturi mask, up to 15 liters per minute, and partial rebreather mask up to 15 liters, and also non-rebreather mask with reservoir bag up to 15 liters per minute, which can provide 100% fraction of inspired oxygen. Here we can see some devices. This is simple oxygen mask using the patient. This is nasal cannula, and this is reservoir mask. This is reservoir mask with a non-rebreather bulb. Here is two bulb present. One is here, and obviously unidirectional bulb. This by this valve only patient can breathe, that is can take the oxygen, and when patient exhale, by this valve carbon dioxide is out and oxygen is stored here, and by this device we can give patient up to 15 liters per minute of oxygen. Here you can see Venturi devices or Venturi mask bulb, which has color code and also provide the fixed amount of oxygen. The blue color provide 2 liters per minute, white color provide 4 liters per minute, orange color provide 6 liters per minute, 8 liters provide, that is yellow color provide 8 liters per minute, red color provide 10 liters per minute, and the green color provide 15 liters per minute. And also there are some device which is barrel. By moving the barrel you can adjust the oxygen. So what are the high flow oxygen delivery devices? High flow oxygen delivery devices include high flow nasal cannula, which are using nowadays in the COVID patient widely, mechanical ventilators, maybe invasive or non-invasive, continuous positive airway pressure, automatic positive airway pressure machines, resuscitation bags, and hyperbaric oxygen chambers. These are high flow oxygen delivery devices. Now something about high flow nasal cannula. High flow nasal cannula can provide up to 70 liters per minute of oxygen and can provide 100% of fraction of inspired oxygen. Simply here we have shown the parts of the high flow nasal cannula. This is the gas source, that is oxygen source, their pressure valves. This is humidifier and nasal interface. We shown the nasal cannula, that is high flow nasal cannula details here. There is a flow meter by which you can adjust the flow of the oxygen, and there is air oxygen blender by which you can give the fraction of oxygen, and it can be fixed 0.21 to 1, that is 21% to 100% of fraction of inspired oxygen. This is active humidifier which humidifies and also heats the oxygen, and through this heated inspiratory circuit patient gets humidified and heated oxygen. And we have said before that by this device we can deliver patient at the rate of 70 liter per minute of oxygen, that is a high amount of oxygen. Here we have shown the devices of CPAP with hood, CPAP with face mask, CPAP with nasal mask. So when a patient comes to you, how you will assess the patient? First of all, if the patient is critically ill, you have to start oxygen. Then check the fifth vital sign along with other sign. What is fifth vital sign? Fifth vital sign is oxygen saturation seen by pulse oximetry. And other sign that pulse, blood pressure, temperature and respiratory rate. And target the oxygen saturation by pulse oximetry 94 to 98% in most of the critical patients. But if patient have hypercapnic respiratory failure such as chronic obstructive pulmonary disease, then target saturation 88 to 92%. Here we have shown a flow chart by which you will give the oxygen to the patient, and how you'll start the oxygen or how you'll reduce the oxygen. If a patient comes, you start the oxygen with 2 liter or 3 liter per minute by Venturi mask or by nasal cannula 1 liter. You should wait for 5 minutes and assess the patient, that is signs of respiratory deterioration present or not, such as increasing respiratory rate, decreased oxygen saturation, and need for oxygen more, and also early warning sign. And there are some sign of oxygen retention, drowsiness, headache, flushed face, and flapping tremor. Then you have to increase the oxygen dose and also seek medical advice from senior. And by this you can go up to 4 to 6 liter per minute, 8 to 12 liter per minute, then 10 to 5 liter per minute, 12 to 15 liter per minute by Venturi mask, and by nasal mask especially up to 4 to 6 liter you can give. After that you should use the simple face mask by which we can give up to 10 liter per minute of oxygen. After that we have to use the reservoir oxygen mask, that is the reservoir oxygen mask which will provide 15 liter per minute. And obviously if a patient requires reservoir mask, then seek senior medical input immediately. And the double arrow shows that you can reduce the oxygen in the same way, and in every step you have to wait up to 5 minutes. After 5 minutes, and if patient is stable without oxygen, then you can withdraw oxygen from the patient. So how we will give oxygen? By categorizing the patient. a critically illness requiring high level of supplemental oxygen. The conditions are cardiac arrest or resuscitation, shock, sepsis, major trauma, drowning, anaphylaxis, major pulmonary hemorrhage, status epilepticus, major head injury, carbon monoxide poisoning. This patient needs a high level of supplemental oxygen. In this patient, start oxygen with 15 liter per minute with reservoir mask and target saturation for 94 to 98%. If the patient is hypercapnic, then 88 to 92%, and ABG should be done obviously in every patient. And also, if ABG shows no hypercapnia in a hypercapnic condition patient such as COPD, that is suspected hypercapnic patient, but in ABG there is no hypercapnia, then target saturation should be as normal target, that is 94 to 98%. But in carbon monoxide poisoning, saturation should be 100% because pulse oximetry can give the false reading. So we have to target for 100% of oxygen in this patient. And in shock, sepsis, drowning, anaphylaxis, major hemorrhage, status epilepticus, you should give the specific management. Obviously, in major head injury, if the patient is unconscious, you have to do mechanical ventilation. Some serious illness requiring moderate level of supplemental oxygen, if the patient is hypoxemic. What are the conditions? The conditions are acute hypoxemia, but cause is not yet diagnosed, it is under evaluation, acute asthma, pneumonia, lung cancer, maybe in the advanced stage, deterioration of the lung fibrosis or other interstitial lung disease, pneumothorax, pleural effusions, pulmonary embolism, acute heart failure, severe anemia, postoperative breathlessness. In this condition, saturation if less than 85%, but no hypercapnic, then you should start oxygen as 15 liter per minute with reservoir mask. Otherwise, you should use nasal cannula or simple face mask. And you know that by simple face mask we can give oxygen up to 10 liter per minute. If patient is pneumothorax, aspiration should be done. If aspiration is not possible, then target saturation 100% and give oxygen 15 liter per minute. If cardiogenic pulmonary edema, then continuous positive airway pressure ventilation or high flow nasal cannula is the choice if coexistent with hypercapnia or acidosis especially. In pleural effusion, usually there is no need of oxygen therapy, but if patient is hypoxic, you have to give oxygen and aspiration should be done. In pulmonary embolism, if patient is hypoxic, should be given oxygen. In post-operative patient, if patient is breathlessness, it should be depend on underlying cause, and that should be evaluated first. Also in acute asthma, pneumonia, lung cancer, and deterioration of the lung fibrosis, if patient is hypoxic, oxygen should be given, otherwise not. Some conditions for which patients should be monitored closely, but oxygen therapy is not required unless the patient is hypoxemic. The conditions are myocardial infarction and acute coronary syndromes, stroke, hyperventilation or dysfunctional breathing, most poisonings, drugs, overdoses, poisoning with paraquat and bleomycin lung injury, metabolic and renal disorders. Also acute, subacute neurological and muscular conditions producing muscle weakness, pregnancy and obstetric emergencies. If patient is hypoxemic in this condition, then start oxygen with nasal cannula 2 to 6 liter per minute or simple face mask at 5 to 10 liter per minute. But saturation, if false saturation, then as usual, before I have mentioned before, if saturation below 85%, then reservoir mask. If dysfunctional hyperventilation exclude organic causes, now sometimes we use rebreathing, but it is now prohibited. If paraquat poisoning or bleomycin lung injury, give oxygen only if saturation below 85% and stop if 88%, because high flow oxygen here can injure the lung more. Neurological and muscular disorder patient need ventilatory support. In pregnancy and obstetric emergencies, if patient is not hypoxemic, should not give oxygen because it can harm the baby. COPD and other conditions requiring controlled or low dose oxygen therapy. The conditions are chronic obstructive pulmonary disease and other conditions causing fixed airflow obstruction such as bronchiectasis, neuromuscular disease, neurological condition, chest wall deformity such as kyphoscoliosis, patient morbid obesity, BMI more than 35 to 40. Those patients are risk of hypercapnia. So in this patient, prior to availability of the blood gases, you should use 24 Venturi mask at 2 to 3 liter per minute, or 28 Venturi mask at 4 liter per minute, or nasal cannula at 1 to 2 liter per minute. In this type of patient, aim oxygen 88 to 92% and adjust target range 94 to 98%. If in arterial blood gas analysis, partial pressure of carbon dioxide is normal, recheck blood gases after 30 to 6 minutes and adjust accordingly. Now I want to talk something about oxygen therapy in COVID-19 patient in very brief according to the Bangladesh National Guideline on COVID-19 version 7. Respiratory failure is defined as partial pressure of oxygen less than 8 kilopascal or 60 mm of mercury, or partial pressure of carbon dioxide more than 6 kilopascal or 45 mm of mercury, or both. According to Berlin definition, ARDS is defined as acute onset of the illness less than 7 days, bilateral pulmonary infiltrate which cannot be defined or explained by others, partial pressure of oxygen and fraction of inspired oxygen ratio is less than 300 on positive end expiratory pressure 5 centimeter of water. So what will be the approach in COVID-19 patient? Actually, we have to try to avoid intubation if at all possible. Prone positioning is very important, more than 12 hours per day, and prone positioning should be given in awake patient and in unconscious patient, but not in restless patient. Except permissive hypoxemia, you can keep oxygen saturation up to 88%, especially in the COPD patient or morbid obesity patient. Use low flow oxygen delivery device first. If it fails, then high flow oxygen delivery devices. If it fails, you can use non-invasive positive pressure ventilation, but in some countries it is not used so much until mechanical ventilation is available, and at last you should use mechanical ventilation as a last resort. Here is a flow chart how we can use oxygen. In respiratory failure management in COVID-19 patient, in mild cases, we can use at first nasal cannula. If not improved, then simple mask. If not improving, then partially non-breathing mask. If not improving, then non-rebreathable mask. If not improving, then high flow nasal cannula. If not improving, then non-invasive positive pressure ventilation, and at last intubation. If it is moderate, that is oxygen saturation less than 92% and PF ratio less than 200, but not less than 100, then start directly with non-rebreather mask. Then if not improved, high flow nasal cannula. If not improved, then non-invasive positive pressure ventilation. If not improved, then intubation. And also in intubation patient, strongly consider a prone positioning. Not only this, in every stages, if patient is awake or patient is unconscious, I have said it before. If patient is in severe condition, that is PF ratio is less than 100, then high flow nasal cannula. If not improved, then non-invasive positive pressure ventilation. Not improved, intubation directly. Now I want to take some time to say about mechanical ventilatory support. We will discuss it about in another video detail. So mechanical ventilatory support, it is used to assist or replace spontaneous breathing. What is the objective? The objective are to decrease the work of breathing, to avoid respiratory muscle fatigue, reverse life-threatening hypoxemia and progressive respiratory acidosis. What are the types of mechanical ventilation? Simply there are two types, non-invasive ventilation and invasive or conventional mechanical ventilation. What is the main principle of mechanical ventilation? The main principle of mechanical ventilation is not to harm the lung. That is, not to collapse the lung or not to over distension of the lung. Here is a graph, you can see pressure and volume curve, and in x-axis there is pressure and in y-axis there is volume. There is a mark. Below the a mark, that is if the pressure is low and the tidal volume is also low, then the lung will collapse. And also above the B mark, if you increase the pressure and also tidal volume, there will be alveolar over distension and there may be barotrauma. But between A and B, this portion is called protective alveolar ventilation. So this is the main principle of mechanical ventilation. So goal of the mechanical ventilation are optimize oxygenation but avoiding ventilator induced lung injury due to overstretch and collapse or recruitment. I think we will talk about this more in our next video. Thanks for watching.